As far as phototherapy, I think that one treatment option is not nearly as common. And not only is it not nearly as common, I will say, or what people have told me, what my peers have told me, it's not as sophisticated. We have phototherapists that have 55 years of experience, that they know how to tweak it. They know how to tweak it safely. They know how to increase the doses when needed, hold back, give them more dose. We know how to add combination therapy. So therefore that we can be more aggressive because we understand the approach, where to manage. I think as you go into certain areas, when people just dabble, what happens when you dabble is if you and even if you're I have a friend who's really bright. I mean, board certified in internal medicine, hematology, oncology, dermatology. She uses a biologic agent 3 times, it doesn't work. She goes, okay, I don't like it, it doesn't work. So when you're just dabbling, an N of 3 changes your whole paradigm off, when really it takes about 40 to 50 patients on a biologic agent or any medication before you start seeing, you get a handle on how effective it really is. So I think that's probably one of the biggest problems. If you're not dealing with things a lot, you don't get the experience in seeing for yourself how effective or how safe a medication is. Insurance companies and patients not being able to afford treatment. In the Medicare population, incredible. People over 65, it's incredibly difficult to get a biologic agent approved. There's donut holes that they can't afford. Even in the regular population. In this area, central New Jersey, it's not so bad compared to other areas of the country where I talk. For instance, in some areas of the country, you have to go on methotrexate before you go on a biologic agent, even though our patient population has relative and absolute contraindications to methotrexate, like hyperlipidemia, obesity, diabetes, that all result in fatty liver, alcoholism, and yet some of the insurance companies require that prior. Many insurance companies require you to go on one biologic agent before you go to another biologic agent. Some people, even with the oral medication, some people are needle phobic, some people just want to try it. They won't let you try that until you fail another phototherapy. Another biologic agent, phototherapy, people could be paying $30, $40, $50 a copay 3 times a week. Some people would want to do a biologic agent, which costs the insurance company $25,000 instead of $3,000 in phototherapy, but they just won't, they don't budge. That's their system. I think the second biggest role is fear. Patients and physicians' fear of utilizing biologic agents because the data that I explained to you about malignancy and infections, they may not be quite as aware of. And so therefore they're still scared, even though Enbrel has been around in development for over 20 years. I mean, over 1 million people have been on it, over 1 million people have been on Humira, 500,000 people on Stelara, and there's, the long-term safety profile looks really good, at least as good as it did in clinical trials. So I think awareness, patients finding the right physicians, and insurance companies really making the costs, or pharmaceutical companies, insurance companies making costs more available to people who need the treatment. No, it's worse. I think what has happened is because of the Affordable Care Act, and this is my opinion, the insurance companies have charged given people higher deductibles. And with higher deductibles, people tend to not come in. Or if they come in, they can't afford to pay. And so they can't afford to pay for their biologics. It makes their medications cost more. First, what we try is many of the pharmaceutical companies have plans that with certain individuals they could qualify for assistance. And we also do a lot of clinical trials. And the clinical trials, we've been involved in all the clinical trials that have been developing all the FDA-approved drugs. So they've come to fruition, they've done very well. And many times we're able to get people into clinical trials. And then even though maybe 1 out of 4 of the first 12 or 16 weeks they get placebo, you know, they could be 3 to 5 year clinical trials, so they get, you know, medication, you know, for free, almost like Cadillac therapy, because they're coming in every 6 weeks, they're getting blood work, they're getting physical exams, EKGs, you know, so we're watching them very, very closely. So that's an option we have. In other facilities, I'm sure in university facilities they have that as well. But I don't think there's a lot of private practices that have that kind of, you know, options. I know a few around the country, but not many. So I think a lot of it's dependent upon the insurance company and the pharmaceutical companies being able to come together and give people a little bit of a break. I tell them there's a lot of snake oil on the internet, but I'm just going to tell you the data that I read the journals. I'm going to tell you the data, and based upon the data, I'm also going to explain to you my experiences in having taken care of either 150 people with this medication or 200 people with this medication and what I've seen. And then based upon that, I think that really calms them down a lot, because once they hear the real data, and you know, and I'm going to give them I'm going to give them a straight shoot for every biologic. I mean, completely transparent. Then they can make their own decisions. Some work better, some are safer. You know, different people have a different risk-benefit profile. Some are willing to take more risks. Some people say, I need to be clear. And some people are like, I'm really scared. And so you have to kind of work with people. And sometimes, you know, you have to be in the same boat, but sometimes it takes a little while to be in the same boat downstream until you get to a decision. And it might not be that first day that you can make that decision. It might be you need to think about it and address the subject a little bit later.